shared out along with a copy of the presentation today after the webinar. So as I mentioned, CSH does a lot of work around the country. We do training and education, lending, loaning, policy, and consulting and technical assistance. My name is Jamie Blackburn. I'm a program manager with CSH based in the New England region, specifically in Massachusetts, just north of Boston. The content today was developed by myself as well as Marcella McGuire, who's our Director of Health Systems Integration. She's actually volunteering at the polls in Philadelphia, so she's not able to join us today, but she had a hand in drafting some of this content, so many thanks to her as well. So you may have noticed I saw a few folks right in the beginning that had played around a bit with the annotation tools. If you look to your left and hover, if you're using a laptop, you should be able to see some annotation tools that will allow you to drop an arrow. Please let me know where you're coming from. And if for some reason the annotation tools aren't working for you, feel free to drop it in the chat. Oh, that's wonderful. So it seems like we have a broad representation from all over the country today. That's wonderful. And I think I saw someone in the chat said that they were joining us from Copenhagen. So welcome as well. Excellent. It looks like we have folks from everywhere today. So this is wonderful and welcome. Wonderful. Okay. Okay. Well, thanks everyone. And we're going to go ahead and get started now. So today, as I mentioned, today's topic is about, social determinants of health. So how to begin this particular conversation? So in 1948, the WHO, World Health Organization, defined health as a state of complete physical, mental, social well-being, and not merely the absence of disease or infirmity. In 1965, the Community Health Center program was launched in the U.S. based on an approach to care developed in South Africa that directly addressed community conditions that drive health outcomes. It's also when Dr. Jack Geiger, pictured here, famously said, "The last time I checked my textbook, the specific therapy for malnutrition was in fact food." And so, where are we going with this? Essentially, what that means is that, and I'm sure that many of you can relate, that there's an increasing frustration within the healthcare sector that's rooted in the fact that outcomes, the expected and desired outcomes cannot be achieved, and that folks are increasingly being required to achieve, but cannot be reached without the ability to impact sectors other than healthcare and outside of healthcare. And that's what sort of introduces this conversation about social determinants of health today. The concept and phrasing of SDOH, social determinants of health, is actually more than half a century old and was first introduced in 1943 in a paper, A Theory of Human Motivation, by American psychologist Abraham Maslow, and illustrated in this lovely pyramid diagram hierarchy of needs. This may be familiar to some folks who may have taken a psych or social class at university. The WHO formally defined social determinants of health in 2003, and there have been iterations of that definition built upon it ever since. In the United States, social determinant of health, SDOH assessments, did not begin to appear in actual healthcare workflows until about 10 years later, in 2013. Social determinants of health are mostly responsible for health inequities, the unfair and unavoidable differences in health status seen within and between countries, populations, and individuals. And although this statement might seem obvious, its understanding is incomplete without a review and sort of an understanding of Maslow's hierarchy of needs, which is why we have it, pictured here. And as I mentioned, that was an influential paper that was written in 1943, titled A Theory of Human Motivation, and it sort of stipulates that certain needs are more basic than others, and that some are more primal and more important and for functioning and for health than others. And of course, shelter, food, air, water, all of those things maintain the basis of this pyramid shown here. So it's really important to use this as a foundation for any discussion of social determinants of health. And please, as I go forward, I'll be doing my best to monitor the chat, and we'll try to answer questions as we go. So please, if you have them, feel free to drop them in the chat. So as I mentioned, SDOH, social determinants of health, are factors and systems that affect individual lives and ultimately have a significant effect on health outcomes. This particular graphic comes from the Kaiser Family Foundation and sums up some of the large buckets, if you will, of SDOH and their ultimate impact on broader health outcomes that tend to be most important to healthcare workers and systems. And so I share this graphic because I think it really provides a lot of detail about how these particular buckets and these broad categories of SDOH can impact sort of on a downline basis other things. So some of them might seem obvious. In fact, I think overall a discussion of social determinants of health can seem very obvious. But, we exist in these various sectors, particularly within healthcare or within housing, and we occupy these silos. And often lines and connections have not necessarily been made between healthcare and housing, for instance. And the purpose of a discussion of social determinants of health and an understanding of social determinants of health is to begin to break down those silos and encourage this cross-systems collaboration, ultimately to improve outcomes, health outcomes for all. Okay. So I think it's also very important before we sort of dive in a little bit deeper into what social determinants of health are, why it's important to screen for social determinants of health and to have a strong understanding within a healthcare delivery system or in a healthcare setting, is to work from a common vocabulary. And there was a couple of really excellent studies that were done. And of course, all the citations for all of the studies that I mentioned throughout this presentation are at the very end of the slide. So all the references are listed in citations, and there's a lot of excellent follow-up reading if you're curious about that beyond this particular session. But there was a study that was done that I thought very important to share, that depending upon the sector that you operate in, whether that's healthcare or housing or behavioral health or mental health, for instance, we're working from slightly different vocabulary, even though we might be referring to the same thing. So it's very important to level set at this stage and understand what exactly it is that we're talking about. So, as we know, social determinants have both direct and complex effects on health. For example, poor air quality, which is common in poorer neighborhoods and communities, can quickly exacerbate asthma symptoms, for instance. Levels of income and education, meanwhile, shape a range of health outcomes, such as prevalence of chronic disease and life expectancy throughout one's life. And then the combined impact of social determinants on health is pretty stark. The poorest 1% in the United States die about 10 to 15 years earlier than the richest 1%. And it goes, to take that even further, folks who have lived experience homeless or severe housing instability, that goes even further than folks who may have stable housing but are otherwise economically poor. Social determinants of health are not the same as population health. Population health is defined as health outcomes of a group of individuals, including the distribution of such outcomes within the group. Social determinants are just one group of factors that shape population health alongside healthcare, genetics, individual behaviors, commercial influences, and others. And healthcare and public health professionals may also have different interpretations of the term population health. And the study that I mentioned was a 2014 qualitative study that found that healthcare leaders of accountable care organizations, ACOs or NCOs, use the term population health to describe efforts to improve care for their own patients, the individuals that are covered under their specific health plan or served by their hospitals or their clinics. For public health leaders, it refers to the whole population living in a geographical area, such as a county or a region. So it's important that we have a shared understanding of what it is that we're talking about with this particular vocabulary. And, the lack of a shared vocabulary could have unintended consequences. So that's why we talk about it. For example, focusing efforts to improve population health only on patients of your own patients may divert attention and resources away from more upstream interventions, like improving overall neighborhood conditions that are needed to improve health across whole communities. Therefore, population health improvement, equals approaches for whole community health improvement, and population health management really means improvement for defined groups of patients served by health plans, hospitals, ACOs, or other healthcare organizations. So I hope that gives you, a little bit of a greater understanding of some of the common phrases that are shared, particularly within the healthcare sector and within the public health spheres. Now, in that same theme, working from a common vocabulary, we need to also make a distinction between social determinants of health and social risk factors. And making this distinction is very important for two reasons. First, it makes clear that social determinants of health are neither negative or positive. Social factors, whether community characteristics, financial stability, social relationships, access to services, or employment status, can increase or well as constrain a person's capacity to be healthy. So in other words, social determinants of health are not things a person can have or can avoid. They affect everyone. And enhancing those protective factors in the social environment, such as access to education, family, and other social supports for children and young people, can promote individual health. And then second, defining and identifying individual level social risk factors can help healthcare systems target interventions to address them. So social risk factors are not the same as behavioral risk factors, which include smoking, alcohol consumption, substance use, lack of exercise, or an unhealthy diet. So in one sense, they're sort of intertwined. Social factors shape individual behavior. There is a higher prevalence of unhealthy behaviors in socially disadvantaged groups or marginalized groups. But modifying individual behaviors fundamentally depends on addressing upstream social factors that shape them. So, for example, individuals asking to manage their weight through exercise and diet are constrained by the environment that surrounds them. Individuals in poorer communities, for instance, are even more constrained by food deserts, fewer supermarkets, more fast food outlets, fewer safe and accessible places to exercise, for instance. And so really one ability to change or to embrace those factors that might improve their health really are greatly constrained by the neighborhoods and environments in which they find themselves. And conflating behavioral and social risks could lead to short-sighted approaches and interventions that focus too heavily on individual behaviors, which really risks widening those overall health inequities because it does not take into account those broader systemic factors that really go into it. And then to add to any potential confusion around some of this vocabulary that we're using, the term behavioral risk factors is also often used in the U.S. as an umbrella term for mental health risks. And so like in the case of behavioral and social risks, mental health and social risk factors can profoundly influence one another, but they're not identical. And then finally, social risks versus social needs. And this emphasizes a patient's role in identifying and prioritizing social interventions. So the idea follows that an understanding of what matters in the context of a patient's life combined with particular clinical expertise is what's needed to make high-quality decisions about the right course of a particular intervention or treatment. So for example, a screening tool may uncover multiple social risks such as food or housing or utilities instability, but a patient might tell a provider that their most pressing need is to find a safe place to stay, maybe from a violent partner. So failing to understand a patient's perspective, which is a common failure, even within the scope of traditional care, could lead to the wrong type of intervention. So it's important that we approach with a common understanding and try to use the right tools to capture what's actually happening so we can tailor those interventions to meet the broader need. So what is the American healthcare paradox? And this is a really important, I think, thing to discuss, that compared to other industrialized nations, and this may not be news to folks at all, but it's certainly worth discussing, that when we compared to other industrialized nations, the U.S. spends much less on social services, much more on healthcare, but it's not achieving the same outcomes. So that is, you're spending more and you're getting less. And that really is the American healthcare paradox in a nutshell. And there's an argument that this is evidence of the lack of attention of healthcare providers giving to SDOH, social determinants of health, despite increasing evidence which suggests that social determinants of health impact health conditions much more than the care they might actually receive in a provider's office. Attention is spent at the point of care to evaluate and motivate patients toward positive, health behaviors, but without addressing social factors, it's difficult to affect positive change. In 2016, there was a study examining nearly a decade of data and found that the U.S. states with higher ratio of social services to healthcare spending had significantly better health outcomes on 7 particular measures, including diabetes, asthma, adult obesity, mentally unhealthy days, heart disease, mortality rates for lung cancer, and days with with activity limitations. And so those states, using a decade of data that had higher social services spending in relation to their healthcare spending, saw better healthcare outcomes across those 7 measures. And so what that tells us is that it's not just the point of care being received in a provider's office, but what are some of the other social supports necessary to assist folks in achieving their goals or particular health outcomes that we're looking for. And this is true despite evidence that social determinants of health, income, educational attainment, employment status, access to food and housing affect an array of health outcomes, especially amongst low-income populations. Another example would be individuals with what we call unmet social needs are more likely to be frequent emergency room department, ER users. They have repeat no-shows to medical appointments, have poor glycemic and cholesterol control than those able to meet their needs. And certainly, at CSH, we see this since the large majority of our work is focusing in on serving ending homelessness and providing support and services to cities and states and counties that are hoping to work towards ending chronic homelessness or improving their homeless response system. And we certainly see that there are folks that have the highest needs and are the most chronically homeless individuals have the highest health needs. They're the most frequent flyers within ERs and detox and inpatient care, and they cost significantly more to the state healthcare system overall, and it's a small percentage of folks. And our analyses find repeatedly that the cost of providing someone, for instance, with a housing voucher and supportive services for a year, the cost savings overall across whether that's emergency care, behavioral health, substance use treatment, justice and corrections, the cost savings overall are quite enormous. And this bears out in every state that we have done these types of analyses. So you may have noticed on the cover slide for this particular presentation, that we say hashtag housing is healthcare. And, it's a catchy little slogan, but why does housing, equal healthcare? And, access to safe, quality, affordable housing, and then the necessary supports to maintain that housing, and that's key, constitute one of the most basic and powerful social determinants of health. And it really is, at CSH, we say that housing, and especially supportive housing for the most vulnerable, and that's where those services and supports necessary to maintain that housing, that's what constitutes the supportive part of housing. We like to say that it is the platform or the scaffold upon which every other achievement or goal will be or could be met. And without having that most basic need, it's impossible to think about really advancing towards some of those other goals that folks might have in mind. And when you think back to the Maslow's hierarchy of needs and the base of the pyramid being, food, air, shelter, that sort of thing, shelter is key. And, it seems when you state it like that, at least it is for me, it seems quite basic. But again, we go back to this theme of silos, and that we all tend to operate within our one particular sphere, and housing is over here and healthcare is over here. And when really we are much more intertwined and there's much more intersection across all of these different sectors than I think most folks give a lot of thought or credit to. And you can imagine if someone, for instance, and this is I think a common example, I like to use, if someone is a diabetic and they need insulin to manage their diabetes, you can imagine it would be very difficult for them to do that successfully without a place to store said insulin. And if they're living on the street or whatnot, you can imagine, and this is one example, how difficult that would be to be able to do that. And then that also applies to many other conditions, but that's one that I typically also refer to. And that's what we say when it comes to substance use and folks that struggle with substance use disorder, that it's quite difficult to think about recovery when one is in a very unstable housing situation. So I think it's important to note that in the United States, housing is not an entitlement. Housing is not a right, and it's not an entitlement, contrary to what some folks might think. An entitlement program in the United States, the most important example of those entitlement programs at the federal level would include Social Security, Medicare, Medicaid, most Veterans Administration programs, federal employee and military retirement plans, unemployment, food stamps, agricultural price support programs. Those are all entitlements in law. Housing is not an entitlement, despite its inarguable position as a vital human need. Federal rental assistance programs help About 5 million low-income households afford some modest housing. About 90% of them include households with children, the elderly, or the disabled. But 15.6 at-risk renter households that are eligible for rental assistance do not receive it due to funding limitations. And 63% of that 15.6 million in the United States are households that have children or are headed by a person who is elderly or has disabilities. And so, this is a policy failing within the United States that we do not have housing as an entitlement or as a right. And so therefore we see this borne out in that American healthcare paradox, where we continue to pour more money than any other nation into our healthcare system and are not bearing the fruit of better health outcomes amongst our population to show for it. And this is one of those underpinning issues that's driving that discrepancy and that paradox. And in some cases, in certain states, even when there is enough vouchers, for instance, the other flip side of that is that there is not enough housing stock which to use those vouchers. And so that's where sort of affordable housing comes in to play as well, that there just simply isn't enough of it. And even if we issued vouchers to every eligible household, we would still have a lot of these barriers because there isn't enough stock that's being built and targeted to middle and low income households in the United States. So again, please stop me if anyone would like clarification or if there are questions about any of this as we go forward. So this is another example. This slide talks about, some of those examples of the direct effects of housing on health outcomes. And we mentioned earlier about how air quality in a particular neighborhood can affect, for instance, or exacerbate asthma symptoms. But substandard housing with poor ventilation, for instance, lead paint, dirty carpets, pest infestation can exacerbate respiratory conditions. This is something that we've seen borne out, across the country. And it's certainly something that I have also directly seen as, part of my work prior to coming to CSH. I worked with a federally qualified health center in Boston, supervising a team of community health workers working in public housing. And one of the targeted initiatives about this was to improve the health outcomes around children with asthma in these particular housing projects, because the health center was seeing, high rates of respiratory illness and issues amongst the children being served from these particular communities. And when community health workers were deployed out to the housing, it was as simple as, giving free vacuums to be able to keep carpets clean, or working with property management to be able to replace carpets or improve the conditions, which then ultimately led to some of the better health outcomes. And this was tracked over several years for this particular grant project. And so that's just one small example of the direct effects that we can sort of visibly see and track, as opposed to some of the broader effects that are a little bit harder to see, but are still otherwise powerful and visible. And as I mentioned also before, that, homelessness and housing instability can affect the ability to manage chronic disease. So I mentioned diabetes, but also HIV/AIDS. And that's for folks that are either infected or at risk. Folks in this particular group might also be aware of PrEP, which is a particular medication that's available for folks to prevent, becoming infected with HIV and to lower one's risk of transmission and risk of contracting HIV. And so if you are an injection drug user, if you are a sex worker, if you are someone that has multiple risk factors for HIV, but you also are homeless or you have housing instability, being able to take advantage of some of those interventions or to lower your risk are much more difficult when you are facing homelessness or housing instability. So we can go on and on of the number of chronic conditions that require careful attention that cannot be addressed when someone is unsure of where they're going to sleep that night, or managing the gauntlet of a homeless shelter, for instance, and not knowing if they're going to have a bed for the evening. It can be quite daunting. So drop it in the chat. Let me know what other conditions outside of the ones that I mentioned might be difficult for patients to manage when they're experiencing housing instability or homelessness. And then we'll take about 2 seconds to hear what you have to say. And I think that this is an important conversation to have, because too often, as we mentioned before, that we zero in on individual behaviors and individual needs that might need, as opposed to sort of zooming out and looking at some of the societal factors that might be driving why someone is unable to move towards behavior change that can impact their health. And so I think reminding ourselves of this fact is really important, another important step to breaking down those silos between healthcare and housing and other sectors that drive a lot of this discrepancy in outcomes. So we see high blood pressure, wound care, mental health, heart conditions, COVID. As a case investigator, COVID is definitely difficult to manage. Agreed. Absolutely. Obesity, substance use disorder, COPD, or anything with durable medical equipment, absolutely. Anything that requires daily medication management, absolutely. Absolutely. That's another example at a risk of talking about my personal experience in my previous life before coming to CSH, but I do think it is important. Prior to CSH, I also worked for a very large AIDS service organization, working with chronically homeless injection drug users in Boston. And we also served a large number of clients who are HIV positive, who are also chronically homeless. And for folks to manage their HIV treatment and the regimen of daily medications every day while facing homelessness was quite daunting. And while there are more housing options for folks that are HIV positive, there are specific housing programs for folks that are HIV positive. There are no specific housing programs to draw from for folks who are just at risk. They have to go through whatever general housing pool or coordinated entry or other sort of general rental assistance. There is no special carve out for folks that are particularly at risk in most states. And then on the flip side, folks that were the chronically homeless injection drug users. Injection drug users are highly at risk for contracting Hep C. We saw enormously high positivity rates, significantly in Massachusetts, significantly higher than those with HIV or for Hep C. And, we do have treatments for Hep C, but it requires, as many of you will likely know, strict adherence to that treatment for it to be effective. And managing that was quite a daunting prospect for most, and so it wasn't undertaken, or they were unable to find a provider that was supportive of them seeking treatment for Hep C until they had secured housing or until they had stopped using substances. And, as you can imagine, this is very, very problematic. I'd like to read out just a couple comments from folks. Even just navigating the way healthcare, primary care is set up isn't meant to support people experiencing homelessness. Having to make an appointment, frontline staff aren't trained on best practice for working with folks experiencing homelessness, et cetera. And that's true. That's true. So I'll say 15-minute late cancellation policies, et cetera. Absolutely. We've seen there is work sort of, I think, advancing to try to bridge some of those knowledge gaps. But, it requires taking a full examination of policies and procedures and trainings from top to bottom to really recognize some of this, all the way down to the way things are coded and how folks are flagged within an EMR and electronic medical record for housing instability or homelessness. And, it's something that really requires a bit of a deep dive into to make sure that everyone is on the same page with. Absolutely. This is all really great. Thanks, everyone. Okay. So how do our neighborhoods impact our health? So we know that, broadly on a systemic level, not having access to housing or poor substandard housing and how that directly affects. And we talked a little bit about this, but I want to dive a little bit deeper. Along with specific conditions in someone's home, the conditions in neighborhoods where their homes are located have powerful effects, on health. And these characteristics really show significant effect on short and long-term health quality and longevity. Neighborhood characteristics promote health by providing, for instance, children places for children to play, adults to exercise that are free from crime, violence, pollution, grocery stores selling fresh produce, having fewer neighborhood liquor and convenience stores and fast food outlets, make it easier for families to find and eat healthy foods. Social and economic conditions, may improve health by affording access to better employment opportunities, public resources such as efficient transportation, an effective police force, good schools. All of these go into the ability for ones to manage health and have impact on health outcomes. Furthermore, concentration of substandard housing in less advantaged neighborhoods only serves to further compound racial and ethnic as well as socioeconomic disparities in health. And this is not accidental. It's not accidental even a little bit. The policies from many decades past on redlining, when investment into particular communities, certain communities were carved out for exclusion of investment, and by extension, the people that live in those communities were denied the opportunities that their neighbors across town were afforded to be able to access mortgage financing and home ownership and that sort of thing. And so particular areas, particular neighborhoods have suffered over many generations of disinvestment. And in the housing world, we're only beginning to have these really direct and open conversations about the consequences of redlining, and we're still digging out from that dearth of quality housing and these long-term health effects and these long-term disparities between different populations really go back to this. They really, really go back to this. I mean, for instance, when you look at, and this is a sort of a personal example that I like to mention, is that even when you look at, for instance, maternal health outcomes, when you compare maternal health outcomes from white women and women of color, whether Native women or Black women or Hispanic women, when you compare these two groups, even when you control for education, even when you control for income, when you control for all of these factors, there's still poorer outcomes amongst women of color for maternal. And what is tying all of this back? What ties back to all of this? What is the underlying cause? We're still trying to dig down to it. And quite frankly, it comes back around to these generations of these social determinants of health that are ultimately affecting these long-term health outcomes that can't be explained by controlling for hospital quality or risk factors in pregnancy or any of these such things. So housing is considered to be, by standard, affordable when a family spends less than 30% of their total income to rent or buy. And the shortage of affordable housing limits families' choices on where they live, and of course, relegating lower income families to substandard housing in unsafe, overcrowded neighborhoods, higher rates of poverty, fewer resources for health promotion, such as parks, bike paths, recreation centers, etc. And then, of course, lack of affordable housing affects the family's ability to meet other essential expenses, placing many under tremendous financial strain. People have to make trade-offs between food, heating, and other basic needs. Another study found that low-income folks with difficulty paying rent or mortgage or utility were less likely to have a usual source of medical care, more likely to postpone treatment and use the emergency room for treatment. Other studies show that children in areas with higher rates of unaffordable housing tend to have worse health, more behavioral problems, and lower school performance. I'd like to read out another comment. Healthcare disparities and lack of healthcare policies in the country further contribute to impediments to chronic disease. Equity for all, especially minorities, is critically needed. I completely agree. In Flint, we're still dealing with the permanent impact of lead poisoning on children and women in particular. Absolutely. That's another perfect example of folks being of chronic disinvestment, of redlining of particular neighborhoods and poorer areas being singled out or ignored for investment and attention to housing. And yes, it's still ongoing. And those are irreversible effects on health because of the lead poisoning in Flint. And it's an absolute travesty. And it all comes back to those social determinants of health. So I do think it's also important to talk about, food insecurity as part of these social determinants of health, right? We talked about food deserts and, lacking when folks live in particular neighborhoods or areas that lack grocery stores, that have an overwhelming amount of smaller food outlets or fast food outlets. It's important to also talk about food insecurity as one of those driving social determinants of health. In response to the COVID-19 pandemic, CSH published a series of resources for community providers because the pandemic exposed the depth of food insecurity experienced by so many Americans. I mean, I think many of us saw in the news the lines of folks lining up for food banks. I personally was involved working with the Greater Boston Food Bank up here and how to get food delivered to folks within supportive housing, particularly the elderly. And so I encourage you, CSH, the link is right here. This paper sort of outlines some of the resources that are available to address food security for health and human service partners around the country. So essentially, it covers some of the three major things, making sure you map out your resources. The Feeding America has an excellent tool to help you find your local food bank or your local, food pantry. So that's a really good place to start. Building relationships with these agencies is really important, and also developing coordinated approaches. And so, building relationships is more than just providing a phone number or making a brief referral or giving out, a website or referring someone to a flyer. It's really about establishing a strong connection with those local agencies that are closest to you and ensuring that referral is really going to be a warm handoff and really be met, as opposed to something that might just go cold for someone. They might not actually receive the services that they need. Oh, thank you so much to Carrie. The Gravity Project has developed a data set for food insecurity concepts for diagnosis, interventions, and patient goals and screening questions. Great. Thank you so much. Please keep the resources coming. I think another great benefit of having these webinars nationwide is that we really get to crowdsource some more of these really excellent resources. So thank you, Carrie, for sharing that. So I really like this particular slide because it really shows us sort of that individual versus community impact. So I really wanted to share this with you all. We often discuss health using sort of the metaphor of a stream right? We're using the metaphor of a stream. That's why I love this graphic. With upstream factors bringing downstream effects, social needs interventions create a middle stream. They're further upstream than medical interventions, but not yet far enough. Social needs are the downstream effects of the impact on social determinants of health, on the community. So individual level interventions are beneficial. While they are beneficial, characterizing them as efforts to address social determinants of health conveys a false sense of progress. These strategies mitigate the acute social and economic challenges of individual patients, but they do so without implementing long-term fixes. They're often limited to a small segment of the population, those who are in the worst health and have the greatest healthcare costs. Meanwhile, those patients who do not rank among the sickest and most expensive are ignored. And this isn't about picking one approach over another. We need social and economic interventions at both the community and individual levels. But improvements in our nation's health and the people of this country can only be achieved when we have the commitment to move even further upstream and change the community conditions that ultimately make people sick. And that is really the root of this discussion today, is that we need both, right? We need those individual interventions for folks to manage their health care, but without those upstream community impacts and effects and interventions, it's not going to get us anywhere to where it's not really going to have that broader impact on health and health outcomes that we need. And we're going to continue throwing money at a problem that will not really won't get any better. And so we're going to wrap this up in a bit, talking about sort of what are some of these next steps, but to address some of this. But I would say we're seeing a significant, at least prior to the pandemic, a significant movement of interest of the healthcare sector in investing into housing, because this is such a powerful theme and a powerful fact that these upstream factors really have deep impact. And so we're seeing a lot more interest from the healthcare sector into housing and these cross-sectional partnerships. And hopefully the pandemic does not stymie this progress that has been made, because prior to COVID, there was really some excellent advances coming down the line on this. Okay, so what are the next steps? Now that we understand and we recognize the fact that upstream interventions are necessary, housing is healthcare, social determinants of health, what can we do within our own sphere of influence and within our own sectors? And so, it really depends. As we saw on the map, we have folks from all over the country, and indeed a little bit outside the country as well. But everyone, shares that they all work pretty much within healthcare facilities. And so, what are the next steps? So, if you're not yet screening for social determinants of health at your particular facility, you might want to begin looking into some of the tools that are available to you to get this done. As my little thought bubble notes, the Uniform Data System results reported in 2019 that 70% of health centers in the country reported collecting data on individual social risk factors, and 23% were in the planning stages. So it's obviously a big priority. Folks are moving towards it. So if you are in that small percentage that are not yet screening for it, I encourage you to take those steps. If you are already capturing SDOH data amongst your patient population, it's important to examine how it's being analyzed and what is the follow-up, because we find that a lot of places capture this data, but then they don't know what to do with it. What is the follow-up once you've identified that these risk factors are in place? And are those warm referrals and those community connections with other social support agencies? Is there follow-through with that? And that's really the third step: examining the referral and follow-up process. I've seen. Many agencies will say, oh, well, we have a resource directory. Oh, we have, we make referrals. But there's a very big difference between a resource directory, which often is not even up to date for most places, and even if it is up to date. We just had a question come in about anyone have a link to a free SDOH tool? Yes, and we are going to talk about Prepare in just a second. Thanks for bringing that up. But having those active partnerships with those social service agencies is really, really important. And oftentimes those connections are not as strong as they should be between a particular health center or healthcare provider and some of these agencies. It's not enough just to have a directory of, oh, well, yeah, we have a local food bank, or, oh, yeah, I think we have a housing provider, but really familiarizing yourself with the organizations and the people that deliver these services, and making sure that you have deep connections that are institution-based, not just person-based, right? So if Sue is the social worker and Sue is the one that is making these referrals, but only Sue has those connections with those organizations, and then Sue leaves and takes another job, and now those connections are lost. We want to make sure that those connections between your organization and those organizations go deeper than those individual relationships, but that institutionally, that there's a really strong understanding and relationship, and really asking ourselves, are we capturing this data? If we are, great. What are we doing with this data once we have it? How often are we looking at it? How often are we making sure that our tools are capturing what we're supposed to be capturing? And then ultimately, what is the follow-up? And what is the long-term follow-up for the person? What is the long-term follow-up for our organization? And what are some of the outcomes that we want to see as a result of capturing this data? And these are all really important things that will go a really long way to advancing some of those broader impacts. And thank you to everyone for sharing those links about Prepare. We are getting into that in just my next slide. So there's two main tools that health centers use for screening for SDOH. Prepare, which was mentioned by some folks in the chat, thank you so much, which stands for Protocol for Responding to and Assessing Patients' Assets, Risks, and Experiences. The same UDS data set reports that about 34.4% of health centers use Prepare in 2019. A smaller percentage uses the CMS, Centers for Medicare and Medicaid's Accountable Health Community Screening Tool. Other agencies, they use tools created for themselves or maybe some other state-level tools. Prepare is an excellent tool. Others use different ones, so I encourage you to look into it. And certainly if you have additional questions, you can reach out to me, and I'm happy to send you other examples. But Prepare is an excellent tool, and if you're not already using it, I encourage you to go ahead and take a look. And it's part of a national effort to help health centers and other providers collect the data needed to better understand and then therefore take action on their patients' social determinants of health. This webinar is an hour. Thank you for asking. We have about 5 more minutes. Just about wrapping it up. Okay, and then finally, some of those next and final steps about SDOH, making sure that staff have been trained on social determinants of health, on how best to approach some of these questions, establishing trust before discussing social determinants of health with patients goes a really, really long way. And I think also and thank you for sharing that other excellent resource on empathetic inquiry training. Excellent. There's a lot of different resources out there to help folks get really comfortable in establishing the trust and asking the questions necessary to get to the data that's necessary to make those interventions and ultimately have the impact that we're looking at. Motivational interviewing, health coaching, all of these types of training. We want to make sure that staff have all the resources that they need to discuss social determinants of health. And then ultimately, we have, the ability to, we know that SDOH is a huge impact on health outcomes, but it also creates what we call the wrong pocket problem. And, we can't use healthcare to assist in food and housing and education. These are outside our sector. So even though someone had a question, are these tools just sharing data, as in client information remains confidential? Absolutely. This is a internal screening tool for providers to use that goes within a patient's chart. It goes within their confidential information. Exactly. Thank you, Carrie. There are EMRs, for EMRs or paper tools for clinics to use. So, of course, it stays within a patient's protected health information. And so how do we address some of these issues, such as housing and education and food, outside of our sphere when we operate within the healthcare sphere? And the answer is to develop new partnerships and to help address some of these issues. So look for your opportunities in your local partnerships, community action agencies, general assistance social welfare offices, food banks, the homeless and housing providers through your local continuum of care, also referred to as a COC. Most places now have what's called coordinated entry, where if someone is facing homelessness or at risk of homelessness, that they can be prioritized for particular resources within a community through coordinated entry. And COC is a collection of organizations within a city or a particular geographic region, or in some instances a whole state, to help prioritize some of those resources. And so connecting with them is really, really important. Domestic violence providers and harm reduction outreach services such as syringe exchange and other things is really, really important. Okay, so as I'm wrapping it up, I know we have 1 minute. I just want to put in a little plug. We are doing a couple of focus groups in relation to health and housing needs, and we would really appreciate everyone's feedback if you're interested. I'm going to put the links in the chat. If you are, actually the links will be, I'll send them out with the follow-up email actually, because for some reason they're not allowing me to put these links into the chat this easily. So please look for my follow-up email with some of these if you're interested. We'd be really happy to get some participation in this. There's compensation for participation, I think by gift card. So please look for that. And then finally, I wanted, if everyone could just take a second, I'm going to share this poll with everyone, and I'd be very appreciative if you could take a second to respond. I'll also be sending this out by email, and I am happy to answer any other questions that folks may have. And I just want to say thank you to everyone for joining and for sharing all of your resources, and I hope that everyone takes away a little bit more information today about those connections between housing and health, and why housing is healthcare, and beginning to, if you're not already having these conversations within your own organizations, to begin talking about either capturing the data or how you're using the data, how to improve on those outcomes, how to use the data better. Today's webinar really was an introductory conversation to social determinants of health, and we certainly could spend a lot more time talking about this on any given day. But I hope that everyone found this to be a good introduction to this particular topic. And I do appreciate everyone taking time to participate in the poll. If you are struggling to find the poll, it should be right under the chat. It should say polling, and then there's a little arrow. You should be able to open up that panel and respond. Okay, great. We're about 50% of folks have not responded, so that number is going down now. Thank you so much. Yes, and I will be sharing these slides as part of the follow-up, and a link to the recording of the webinar, as well as information about the focus groups. Absolutely. And of course, I am happy to answer any questions or share any other resources that folks might have. Please feel free to email me individually, and I'm happy to reach out and answer any questions that you might have.